Hi, everyone. Um, Decided we're going to do another ECG this week uh, in the hope that we can actually lead up to a topic that I've been wanting to do for a little while on ECGs as well, that I often find doctors struggle with, especially the juniors. Not all of you. Some of you are ready to start as cardiologists from the time you come out of university, but let's just say the vast majority of us mere mortals do struggle with some topics. So we're going to have a look at another ECG this week, and then we'll take it further from there. So this week's ECG, we've got a 47-year-old woman with chest pain, now pain-free after use of sublingual nitroglycerin. Now, we've been through enough of these, and if you've been following along, that this should already spark your interest, even as soon as you hear the history that this could well be ischemia. You don't rule out other possibilities. For example, a pulmonary embolus is still very possible, especially with the use of nitroglycerin, its vasodilatory effects, but it's unlikely. Especially once you use TNT and the patient starts to feel better, your mind immediately starts going towards the cardiac and what could be going on and things like that. So in this one, we're going to have a look at a particular case that I've actually faced quite a few times. Surprisingly, it's not that uncommon. And it's one of those things where, working in the emergency department, remember, your job is not to completely diagnose the patient, but just to decide, is this dangerous and does this need more? And this is one of those cases, and we're going to get into it now. So we're going to analyze this. We're going to go through our normal way of analyzing, and then let's take it from there. So if we had to look at our I'm going to avoid the drawing this time. You really, by now, everybody should know how to work out the axis. But if we look at it, lead 1 positive and lead AVF sort of biphasic. So we would say that it's at 0 degrees, or it's, pointing directly at lead 1 sort of. Not 100%, but kind of there. This one here is actually just leaning a bit more towards the left. And, but it's within normal. So that's normal. Now, let's look at our rhythm strip just so that we can see. So the first thing that we notice, we've got very peaked P waves. Now, this can be due to positioning. So in other words, the actual position that we put our leads on, and in order to make sure, just compare it to some others. So this was initially when I went through this, I also thought, oh my God, peak P waves, are we looking at a valvular problem? Are we looking at an atrial issue? And then when you start to look at it, you start to realize, no, it's really just lead 2 that's kind of looking at it in that way. If you go through any of the others, maybe V1 you could exclude, but once you start going through the others, you start realizing, hey, you've got relatively normal P waves. So always just look at that. Generally, if there's a problem, it will be manifest throughout. But if you were to say this was an abnormal morphology, I don't think anybody would argue with you, and it may just be showing a bit of atrial strain. I would suggest it's more on the right-hand side than the left. The reason being, the first half of the curve normally shows the right atrium, which you can see is taking a bit longer than the left atrium in this case, but it's not really an atrial issue, and we'll get to that just now. If we look at our PR interval, it's more or less normal. Our QRS complexes are narrow. A QRS complex follows every P. The PQRSs are relatively regular. There's a bit of sinus arrhythmia, which we get as we breathe in and out. That's quite normal. So we've got a relatively normal rhythm. And if we look at our rate, we're looking at 1, 2, 3, 4, almost 5. So between 60 and 75. So let's put it closer to the 70 mark, 75 mark. So let's say about 70. So relatively okay. So we really are looking at an ischemia. So let's have a look and see. So we're going to go through each zone. Let's look at the inferior zone first. So we look at leads 2, 3, and AVF. And the one thing that we notice is we've got a very mild ST depression, more notable on those 2. Now, I had discussed this previously with another group. This was quite some time ago. This is actually an older presentation that I pulled out. This was long before we started recording. And there was a question as to whether this is a Q wave. And the answer is that no, it's not, because what we've got is we've actually got an RS. So always be careful, always look out for those little things over there, but this is not a Q wave. But if it were, it wouldn't be abnormal considering what we're seeing in the rest of the in the rest of the ECG. So from the inferior, we see that there's some ST depressions. If we go to lead V1 and V2, one of the things we notice is this M pattern that we've got over here in V2. We've got a slight ST, maybe let's say a little saddle forming over there, but inconsequential. Here we've got it dipping into a what you call it, inverted T wave over here, but we'll get into that just now. But what we've got is we've got this little M shape over here, which is normally indicative of a right bundle branch block. Now we're going to talk about that a little bit in a little while. This is an incomplete bundle branch block. It has to do with the time. So an incomplete bundle branch block is normally quite short, whereas a complete bundle branch block just stretches a bit more and has one or two other features which we'll talk about now. Now, right bundle branch blocks in and of themselves, if you find an isolated right bundle branch block on an ECG, it's not of much consequence. It doesn't tell you much. But in looking at a big picture, it may tell you quite a bit. Okay, so if we look at V3 and V4, which are now your anterior, this is we are looking at the septum. Now we look at the anterior. What we notice is these very deep inverted T waves. Now, these are actually quite worrisome. Now, if at this point you didn't know what was going on and you said, listen, I'm worried because of these T wave inversions, which are quite non-specific. Generally, T-wave inversions are non-specific, but you say, okay, I know T-wave inversions are non-specific, but we know the lady had chest pain and she's feeling better. The best you could do at this point was at least work the patient up and say, listen, we suspect there's going to be a blockage over here. Let's get this patient in either for an angiogram or let's get this patient thrombolized after discussing with the physicians. And then your physician walks in, looks at this and says, oh my God, we need to get this patient into the cath lab or into ICU immediately. And we'll get into why that is. And this is an important pattern to remember because of that. But we do see slight ST depressions, more pronounced on V5 and V6, but again with these deep inverted T waves. And I just want that just to keep ringing in your head. Deep inverted T waves, deep inverted T waves. Just remember that. We're going to talk about it a little bit more because it's something that we need to know. And as we come to the high lateral lead, so 1 and AVL, we see a bit of an ST depression, again, an inverted T wave. And this is what we would not worry about normally, or what we would say is non-specific, an inverted T wave like that. And if you look at AVR, you can actually look at what seems like a slight ST elevation, but when I actually looked at it, it's not actually that. It's just more of a saddle shape. So always be careful that saddle shapes can sometimes look like ST elevation, but when you actually put them on the net zero line, let's just do it here. I hope it will let me do it. Okay, let's try it with this. So if we put them on the net zero, so this is in other words the zero line. And if we come across, there you can see that's an ST depression. Okay, I was hoping to show it, but now it's going to block me off. So unfortunately, I can't show it. But if you were to do the same thing here, just apply a line across, you would see it actually intersects. So the lines would actually be there, but the saddle shape can sometimes give it this impression of an ST elevation. So we know this patient has an ischemia. And if you reach that point, that's very good, because even if you said it's an NSTEMI, you're not really sure what's going on, but there are ST depressions, there's maybe an ST elevation there, we'd be quite happy with you. You'd have done well as a junior doctor to say, listen, there is an ischemia going on. It's quite scary because it's not something you'll see all the time. But if you picked out ischemia, you did quite well. Now, why this is quite important, why I say deep inverted T waves, is because this is going to actually tell us quite a bit. And I brought this up because of the tendency to maybe call this an NSTEMI. All right. So what we have, let's look at our, so the rate, 85, sorry, I must have, yeah. Anyway, getting old now, I can't remember everything. Incomplete right bundle branch block, which we came on. T-wave abnormality consistent with inferior and anterolateral ischemia. Okay, so acute ischemia as compared to an NSTEMI. All right. Now we're going to talk about the subject a little bit more. So in 1982, Wellens and colleagues described two T-wave morphologies in the mid-cordial leads that are highly specific for large, proximal, left anterior descending obstructing lesions. The more common morphology is a symmetric and deeply inverted T-wave appearance, which we saw, as shown in this case. All right. The less common one is the biphasic T waves in V2 and V3, which I must be honest, I've missed many times. And I'm so ashamed of myself. This was at a time when I was just starting in emergency medicine. I barely knew how to diagnose normal STEMIs and NSTEMIs. And I remember 2 or 3 patients that I missed this on. And it's quite embarrassing if you are working in an emergency department, because somebody would ask you, and I remember my consultant asking me, is that a normal T wave? And you look at them and go, no. And then they say, well, why didn't that spark something in you? Even if you didn't know what it was, you could have asked. And you realize, okay, listen, it's abnormal. I should have asked, So this T wave abnormality is now known as Wellens sign. And the thing is, it persists even in the pain-free state. Now, remember, we had discussed previously proximal LAD, all right, proximal LAD lesions as well. And we mentioned that where we've got elevation in AVR, ST elevation AVR, and it also has a pain-free state. Although the difference being in this one, the patient was given nitroglycerin, so the lesion is probably a bit well, it's still proximal, so that's the thing. But the thing is, with the proximal LADs, the reason why they give you this is because of denervation as well. So you get quick denervation of the nerves that are surrounding. So you also get this pain-free state that comes around. Medical treatment is often unsuccessful in preventing MI or death. So this is one of those where thrombolysis is not really indicated, and it's one of those where if you treat it as an NSTEMI, you're really going to go quite wrong. And invasive therapy with angioplasty or stent placement is more successful. In fact, like, just for those of you who maybe are not working in our setting, like we're working now, semi-rural, and even our tertiary hospitals, they're not flooded with cardiologists and cardiothoracic surgeons. So they would not necessarily go for angioplasty. They actually go for stents most of the time. And there was a recent case of a stent actually being unable to be passed, and then they got passed on to the central hospital in Durban, and that's where they actually managed to do quite a weird angioplasty. Hi, sorry about that. We just had an internet issue, so the Zoom recording stopped as well. Yeah, so carrying on from there. So, yeah, as I was saying, so there was a patient I heard from the medical guys who eventually had to be treated at one of our central hospitals. So it might be tempting to do thrombolysis, on these patients, but they don't often respond very well. So this is why I said, just keep it in your mind, deeply inverted T waves. Just keep that in mind, biphasic T waves. So this is what we would see in a non-Wellens, let's put it that way, and as how they put it here as well. Right, so this can be considered an ischemic event, but these are more non-specific. Now, if you compare these to the deep inverted T waves, it shows you quite a difference between the two. And then we talk about the right bundle branch blocks as well. So complete versus incomplete. So the complete generally is more than 0.12 seconds, which is about 3 blocks, and an RSR in lead V1 and a QRS in lead V6, which I know none of you will ever remember. Even I can never remember it. Basically, a wide right bundle branch block, so that M shape, W shape on leads V1 and V2 will generally indicate a complete right bundle branch block, whereas an incomplete right bundle branch block, like what we had on ours, will generally be a lot smaller, or let's say a lot thinner than what it's supposed to be. So let's just talk about Wellens syndrome just for a second. We're almost finished. So it's a clinical syndrome characterized by biphasic or deeply inverted T waves in V2 and V3. But as we saw, it can extend quite fast. So in ours, it went up to V3, V4 as well, and it's highly specific for critical stenosis of the left anterior descending artery. All right. So this is often the history that's given. It's chest pain, now resolved, denervation, all these things that occur, So the pattern is usually present in the pain-free state. So you have this patient who you assume is actually doing okay. And then once you see this, it needs to get you worried because this patient's ischemia is ongoing. Okay. So the pattern is usually present in the pain-free state, may be obscured during episodes of ischemic chest pain, where there's pseudo-normalization of T waves in V2 and V3. Although I must be honest, if you get that pseudo-normalization, you probably already have a Wellens that might be showing up, you know. And Wellens syndrome is a key example of why all patients presenting with chest pain must have serial ECGs. And this is something I haven't really spoken about before. But ideally, all your patients should have one on arrival, one at 15 minutes, one at 30 minutes, 45. So in other words, at 15 to 20-minute intervals. Now, in a busy emergency department, that's not always possible. So at least one on admission, one at 30 minutes, you know, or sorry, one on arrival, one at 30 minutes. And then based on what you find, then you do further serial ECGs. But at least if you have two, it shows that you are checking it. And I must commend a lot of the doctors that I've worked with over the years. Generally, when you do get a very sick patient, most of the guys do at least at 10 to 15-minute intervals. And it's what you have to do as well, okay? So patients may be pain-free by the time the ECG is taken and have normal or minimally elevated cardiac enzymes. However, they are extremely high risk for extensive anterior wall MI within the subsequent days to weeks. And in fact, it has a very high mortality rate. So please remember, these patients are in a lot of danger. Don't just assume that they're going to be okay. And that's why I said when the physician walks in, physician sees this, they immediately, they get worried because they know this can go quite badly, you know. So, and like I say, these patients often require invasive therapy. They do very poorly with medical management, and they may suffer MI or cardiac arrest if inappropriately stress tested. So, you know, these types of patients, they often, they prove to be a problem for us in the emergency department setting because now they are pain-free, or they've taken something, or they were in a lot of pain, but it suddenly just stopped on its own. And you see this. So what I'm saying to you guys, if you get a patient with chest pain, do the ECG, deep inverted T waves or these biphasic T waves, immediately think to yourself, something's going wrong. The cardiac enzymes are not going to take you very far because they actually don't have elevated enzymes, because they most of the time they present to us within the window period for enzyme elevation. So you can't really rely on that. It may sometimes, but it generally doesn't. And a lot of these patients, they come back with normal TROP-Ts or TROP-Is and CKMBs. And it's hard sometimes, especially depending on the setting that you work in. I know in our case, we often have very junior medical officers sometimes in charge of a department for a night. There's no registrars, there's no consultants per se, on the floor. So you have this issue where the person will just tell you, well, the cardiac enzymes are not elevated, it's not important. And even when you try and explain to them, they may not get it. So it's difficult because you have to advocate for your patient as best as you can. And generally, if you are stuck, use something like this. Say, listen, let's have a look at this on the net. Let's go online. Let's have a look and see what Wellens looks like and what it is. So I remember a few cases over the years where I've had to explain to doctors that, listen, I know you don't know it. That doesn't mean there's something wrong with you or that you're a bad doctor. I'm just telling you that this gap in your knowledge does not mean that it does not exist. And doctors often feel, because I've never heard it, it doesn't exist. You have to explain to them, listen, this is not an insult to you. This is not something that I'm telling you are deficient. I'm just saying this is something I know. This is something that you don't know. So I'm just explaining it to you so that you know that we have to take it further. I'm not doing it to irritate you. I'm not doing it to make you feel small. I'm just telling you, listen, there is such a thing as Wellens, for example. And Wellens causes this, and we need to take it further. And a lot of people, even you yourself, if somebody had to come to you and tell you, well, listen, this is something that you don't know, but this is what it actually is. In your own mind, if it's done pleasantly and it's done properly and it's explained to you, you will change your mind and say, okay, I didn't know that, I really didn't know that. I think back to a few years ago, I had a patient with iron ingestion. And I was dealing with a medical officer who didn't realize the amount of liver damage and gastric damage that takes place with iron ingestion. He really just didn't know. He thought, oh, okay, it's iron ingestion. We send the patient off to the ward and I'll see them later. It's like, no, this patient needs ICU, and I explained to him what happens and pathophysiology and everything that happens to it. And after he's like, okay, I didn't know. He apparently, I think he went on his phone, he checked it up, and then he came rushing to the emergency department. He's like, okay, no, thanks. You taught me. At least I know now, the next time it happens, because it wasn't something that we see very often. So always be kind to your fellows and understand that sometimes they may just not know, or they may be, I mean, we've all slept away during lectures. Some of you may be asleep right now, but it can happen that we miss something. So anyway, that's just a joke to finish off. So sorry this was done in 2 parts, simply because of the internet connection. But I hope you guys learned something, and we'll try and cover left bundle branch blocks the next time. It's something that I've wanted to do for quite some time and just haven't gotten around to it. Okay, keep well. Bye.